Welcome back to the MedEdit podcast, your go-to source for evidence-based medical education.
And the only podcast where two board-certified physicians interview specialists on the topics you care about. All right, 50 to 70% of women report genitourinary symptoms of menopause, which I think is probably grossly underreported. We have a return guest today, nurse practitioner Kristen Sharma, aka our urology guru, to break down the facts about the silent, underreported burden of menopause.
She's going to break down what the symptoms are and how they are treated. Then she will join us for the game of fact or myth.
So let's get started. We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray. Welcome to the MedEdit podcast. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
I just want to start by saying if you haven't listened to her episode on overactive bladder, go check it out now. But just as a reminder, Kristen Sharma is a certified family nurse practitioner with experience in the field of urology at TTU HSC and University Medical Center here in Lubbock. Welcome back to the podcast, Kristen.
Thanks for having me again.
I think this is the perfect time to discuss this topic because, as you've mentioned and I've seen as well in the news, the American Urological Association just recently released new guidelines on genitourinary symptoms of menopause. And even the term genitourinary symptoms of menopause is something that has evolved really over the last roughly 10 years or so.
Yeah, the release of the guideline was so exciting, and it really is a movement, forward for women's health care. It really reaffirms what I do in my clinic every day, but really, most importantly, it empowers other providers, especially PCPs, to be treating genitourinary symptoms of menopause and treating it well. This was previously referred to as vulvovaginal atrophy or just vaginal dryness and even senile vagina. But the thing is, it's about more than vaginal dryness, and it's very important. And that's why I'm glad to be here talking about it with you today.
I know. I think you, on many times we have talked, you've been like, I'm so excited for these guidelines. They're coming out. They're coming out. So they're finally here. So I feel like this is like the big unveiling, and we get to actually talk to you shortly after it. So this is great. Just so we're on the same page, menopause describes the stage of a woman's life when her menstrual periods, they stop permanently, and then she can no longer get pregnant, right? That's just like the basics there. It is a normal part of aging for women, but symptoms associated with this transition can be debilitating for some women. Every woman has a different experience, right? Some women go through it and say, hey, I barely had any symptoms, and those are the lucky ones, right? And some ones have debilitating symptoms. And so it's having some guidelines is really beneficial. Most women begin the menopausal transition between ages 45 and 55. And of course, that can be very varied per person. And the process may last for a few years. Women reach menopause at different ages, and the average age of menopause in the United States is 52 years old. So, Kristen, let's start with the basics. So, what are the genitourinary symptoms or the genitourinary syndrome of menopause?
So that is basically different signs and symptoms that can be attributed to, lack of hormones, essentially, in the vulva, the vagina, the bladder. So we have different kind of buckets of symptoms and signs that we can see. So for example, some of the urinary symptoms can be urinary frequency, urinary urgency, incontinence, painful urination, and even UTIs. We'll talk more about that. The genital symptoms can be the vaginal dryness, vaginal irritation, and sometimes that can mimic things like yeast infections. So that's kind of a differential to think of when someone's complaining about itching and dryness. Sexual symptoms, so pain with sex is very common because of the thinning of the tissue. Again, we'll get to more in that. Even bleeding with intercourse, reduced libido, arousal, orgasm, all of these things can be due to the lack of the hormones. So those are some of the symptoms that patients may come in with. And then signs on physical exam, the thinning of the tissue, the change in the pH, again, some bleeding when you're just examining a patient, ulcerations. So there's a lot involved. Now, when you read the guidelines, it talks about how there's not a consensus to, okay, you have to have this many signs or symptoms. It all kind of comes down to bother. So again, with someone like me who is seeing the majority of postmenopausal females with urinary complaints, I mean, this is a discussion I'm having all day long.
Interesting. Yeah, I think that's great information. And I think we kind of prefaced this a little bit on why it occurs, but just so all of our listeners too, why do these symptoms occur along with menopause?
So basically, it is due to a lack of hormones within these tissues. So not only estrogen, but androgens even are very important to these tissues. So when we lack the hormones to the tissue itself, it thins out and it becomes very friable. And again, leading to irritation, pain with sex, those sorts of things. There's a change in the pH of the vagina. So then all of that good bacteria in the vagina, the lactobacilli go away, and that can lead to infections. The lack of estrogen within the bladder leads to an increase in the mechanoreceptors within the bladder. So then as the bladder's filling, we get more irritated. So again, leading to symptoms of like frequency and urgency. So there are so many changes that happen again, just due to lack of hormones.
It makes perfect sense because that's what everyone's talking about, like on social media and all these things. And I think it makes all these women think, okay, you have to be on hormones, but it's not necessarily a have to. It's a what do you need? What are your symptoms? And so being open and honest to having this discussion about maybe some symptoms that you're really embarrassed to have that conversation with is really, really important. So if someone does come in and they say, okay, I'm going to be honest with you, these are the things I want to talk about. I'm having these symptoms that you just described. How do you, as the medical provider, what should the patient expect? How do they diagnose what's going on? And they say, yes, this is from, menopause. Because we talk about this all the time. We don't just blame hormones and say, well, it's just your hormones. And even if it is, how do we deal with it?
So, of course, we start with a history and we're asking all of the questions about the symptoms that we mentioned earlier, the urinary symptoms, the genital symptoms, the sexual symptoms. And then when we do a physical exam, we do a pelvic exam, preferably on all of our patients if they say, okay, that's okay. So again, we're looking for any physical changes and anything that may be, also contributing. There are other processes, like I mentioned already, like yeast infections that can cause maybe similar symptoms. We want to make sure that we're not missing any vulvar dermatoses, any malignancies, any signs of infection. With that being said, a pelvic exam is not required for the diagnosis. Okay, so yes, we want to make sure that we're not missing something, but we don't want that to be a limiting factor in someone getting this diagnosis and getting the care that they need. No testing is actually required to make this diagnosis. Again, it's a clinical diagnosis. A couple of things that we could potentially do. So when I do a pelvic exam, oftentimes I will do a Q-tip exam. So you're just taking a cotton swab and you're touching the labia, the vulva, the urethra. And sometimes when you're doing this, you will literally touch the urethra and be like, that's my UTI. Like I feel the same UTI feeling. So, and in my mind, I'm like, okay, are we dealing with true infections? Are we having positive cultures, or is it just that this tissue is just unhealthy and that we need to replete the estrogen and the androgens to that tissue? pH testing can be helpful in some scenarios because, again, the pH of the vagina changes in menopause, but that, again, is not necessary for the diagnosis and it may give variable results. So something that we do occasionally.
Okay. And are there certain groups that might be at higher risk for getting these type of symptoms? Like, is there any rhyme or reason on who's going to get worse genitourinary symptoms with menopause?
Yeah, so we think of it as a chronic progressive condition, unfortunately. So it is my older patients who actually can present with some of the more severe symptoms, or at least on physical exam. So that is definitely a group where, sometimes I'm doing a pelvic exam and unfortunately these women are tearing as I'm just touching and separating the labia. Or kind of the opposite where we develop labial adhesions. That can be very uncomfortable and, mimic signs of UTI and yeast infection, those sorts of things. Other patients who may present with a little bit more severe symptoms are my breast cancer patients who are on estrogen blockers because it just kind of magnifies these symptoms. And we'll kind of talk a little bit more about that and kind of how we consider treating genitourinary syndrome of menopause in my breast cancer patients.
Yeah. I think one important thing is to also, as women, not let your female family members gaslight you on menopause, because I feel like more than anything, I hear like mothers, grandmothers being like, well, mine wasn't that bad. You'll be fine. Like, mine wasn't severe, or no, you can't have that yet because I didn't have those type of symptoms till I was much older. So, what you're saying basically is that it can start, even younger than we suspect. So you definitely want to tell people if you're having these symptoms, and just because you don't necessarily have a family history of severe menopause symptoms, or, that just wasn't talked about, does not mean that you don't. So I just wanted to put that as a PSA, because I do hear that pretty frequently as far as for even, I think it ranges all the way from when periods start to menopause, but it's always like, well, mine wasn't that bad, so you should be okay.
Right.
Okay, so what are some of the non-hormonal and hormonal treatments that may be used to treat these symptoms? And then you just talked a bit too about the breast cancer survivors, so expand a little bit more about that for us too.
Sure. So traditionally, the first line therapy was recommendations for moisturizers and lubricants, and those definitely still have a role, but they're not going to address the root cause of the problem. So moisturizers can help increase the water content of the epithelium, and then decrease the vaginal pH. So those can be helpful. Lubricants can be used as needed for sexual intercourse to make things easier and alleviate symptoms of painful sex. Hormonal treatments really are now considered first line, and there are many treatments that we can discuss today. What's great is our guidelines spell out for you exactly how to do this and the appropriate dosing for all of these options. So I really do encourage everyone to look at our guidelines because they're really well done and very helpful. So first line, typically I start off with sending an estradiol cream. It's easy to get. Insurance is paying well for it in general, and if not, I can get one tube for $13 with Mark Cuban's Cost Plus Drug Pharmacy. I've been doing this for 3 years, and the cost has dramatically gone down in the last 3 years, which is great for access, and it's fantastic, and it's easy to use. So it's 1 gram of cream inside the vagina twice a week kind of forever, okay, indefinitely. So if we stop treating the genitourinary syndrome of menopause, all of the symptoms can come back. So that's one option. Another option, there's another cream called Premarin cream that has been out for a long time. I tend not to send it in too often because it does have alcohol in the base, so that can be a little irritating, and it's still considered brand name. So when I ask patients, okay, you're on that, you like it, but how much are you paying? And they'll tell me $90. Like,
Wow.
that's just, I don't want them to waste their money. Like, yes, I love vaginal estrogen cream, but let's spend your money on other things. So oftentimes I will change that. So that's another option as far as creams that people are familiar with. Now, oftentimes I'll have patients come back and be like, yeah, I'm using it, it's okay, but they don't like how messy it is. And when that's the case, we can do vaginal inserts. So there are like little tablets and there are suppositories that you can put inside the vagina, and they tend to be a little less messy. So patients like those. Sometimes cost is a little bit more of a barrier, but it definitely is an option. Another option is a low-dose vaginal estrogen ring called the S-ring that you can put inside. And I feel like that's a really good option for my patients who may not remember or may have some physical limitations for using the cream. So either, patients can come in and see their provider and have them change it out every 3 months, or, the patients themselves or even a family member can help with that. And it's great because then you don't have to remember to do it.
Now, is that one that needs to be done in a urologist clinic, or is that something that can be done in a primary care setting? Because I've never done that with any of my patients, but that's such an interesting concept. If they can do it at home, it's one of those things that we could have a conversation in the primary care setting. So tell me a little more about that, because I do see that you guys use that quite often.
Yeah, so I mean, it's definitely something that you can put in. Sometimes home health will put in the rings for my patients. So instead of them having to come to the office every 3 months, sometimes I'll be seeing these patients about that often anyway. But if it's one less trip to the doctor's office, I think that's fantastic. And then for primary care, yeah, if you want to, I don't see any reason why you can't. So yes, please order it.
Yeah.
The problem is that unfortunately coverage varies. Okay,
Right.
so a lot of my patients get denied. We try.
Mm-hmm.
Hopefully that'll get better here in the near future, but it is a really good option.
So I think of it kind of like the same questions that people ask when they talk about like the Nuva ring or something too. Can they have sexual intercourse with the E string or S string?
Oh, yeah, definitely. They definitely can. The thing is my patients who tend to use these tend to not be sexually active, but it
Hmm.
definitely is not a contraindication. My prolapse patients, we may have some difficulty with it falling out, but in general, that's not really a problem. It's really not something that they even feel or complain about. So it just needs to be changed to, every 3 months, and it's a really good option. So that's a ring. So then there's a couple other options. Now, before I kind of move on, the reason why the ring and the inserts that we were talking about can be a really good option is because when they do testing on systemic levels of estrogen, it's very negligible. Okay, so if you do testing, it'll basically still show postmenopausal levels. So, for our patients when we're ultra concerned, again, I feel very comfortable giving vaginal estrogen to nearly all of my patients, but when we are concerned a little bit more, the patient themselves is a little bit more hesitant, the inserts and the ring kind of have the least amount that it's going to get into the body, just
Just
as an
acting
FYI.
locally there. That's such a good point.
Yeah, because the cream is just a little bit more variable for, how patients are using it and how much they're getting. So the ring and the tablets are just better set amount. So um, the other options, there's a vaginal DHEA that can be used. So the DHEA gets converted into estrogen and testosterone within the cells of the vagina. So that is a really good option. The problem is access with that because it's often not covered, but it is a good option, and that has been shown to help with not only symptoms like painful sex, but also decreasing the rates of UTIs. Um, there is also a pill called ospemifene that can be used. It is a SERM, so a selective estrogen receptor modulator, that has shown to help with the vaginal epithelium and the dryness. There is it can cause a little bit of proliferation of the endometrial lining, but it is not associated with any cancer or hyperplasia. So it is still an option, but it has a little bit more risk involved to it. Honestly, I haven't used it all that often, but now that it's part of the guidelines, it is definitely something to be able to offer patients. So those are the hormonal options for you.
I love it. There are quite a few. And again, as a kind of a reminder for a listener, she hasn't mentioned any actual oral estrogen in all of that conversation, right? So obviously oral estrogens are a whole other discussion for their
Mhm,
uses, but and systemic uses, risks, benefits. But just talking
mhm,
about the genitourinary symptoms, which
Mhm.
are oftentimes very common symptoms, and this targeted therapy kind of would say that's non-systemic really does have a benefit that you can pretty quickly, I think, as well, right? That how long does it take for these hormonal options?
yeah, about 3 months or so to kind of get that full effect. We'll counsel patients. Some people will notice a difference very quickly, but then some patients it takes a little bit more time. And as we talked about earlier, not only do we have the estrogen, but we need the testosterone as well. So once in a while, if the estrogen alone isn't helping matters, we may need to consider like topical testosterone or even that DHEA. But that may be when you want to, get a specialist involved, if you don't feel comfortable with kind of managing that a little bit more. But
And
most
so then
people
you
will
said
respond really well.
that's good. And then you said about the breast cancer survivors. Tell us more about
Yeah.
that and their options because I have had several of my patients that they were diagnosed with breast cancer while they were already on even they could have been on systemic, but then I have some that were just on vaginal topical treatments, and we stopped everything in that moment they got
Mm-hmm.
diagnosed. And then the whole discussion was we'll put a pin in it, come back later to talk about that again. So with the new guidelines and everything, I heard through the rumors that there was some advice or some changes on that too, right?
So in general, it's going to be a shared decision-making model with both the patient and the oncologist. In general, yes, if there is a breast cancer diagnosis, we will definitely stop the vaginal estrogen in that moment until, we figure out kind of what's going on as far as treatment. Uh, Now, with that being said, there's a lot of kind of nuanced data. Last year, Australia came out with these really great guidelines on depending on the type of breast cancer, depending on what kind of medication, endocrine therapy they may be on. advice as to, okay, this is not okay. Um, in general, again, I'm having that discussion with the oncology team. But the exciting thing is some of the breast oncologists are even prescribing vaginal estrogen. So, I will have them talk to them, but in general, the oncologists are saying, yes, that this is okay. Now, we are a little bit more hesitant in our patients who are on aromatase inhibitors.
Mm.
But again, that's when we have that discussion. But I have plenty of patients who are still on their aromatase inhibitors and we're using the vaginal estrogen. So it's not a never thing, but it is that discussion. And I think every breast cancer patient needs to at least be told that this is a possibility and to be able to make that decision for herself, because I have some breast cancer patients who are, of course, even maybe decades out and still afraid and still don't want to use vaginal estrogen, and that's okay. But I think we should at least be giving them the option, especially if they are suffering with painless sex, UTIs, all of those things.
I think it's really good advice for sure.
Oh, absolutely. And I think you're right, because we talked about this not that long ago too, about how there was this whole shift between using hormones for a lot of these symptoms. Like everybody was
Hmm.
doing all of it. And then it was like a complete stop was put on it. And then it took, I don't even know, like decades basically to get back to the point where even
Yes.
vaginal topical estrogen was even recommended in any women, much less, like you said, breast cancer survivors. So what are the most common misconceptions that you hear about using, topical or the options that you mentioned on hormone therapy
Mhm.
for these type of symptoms?
So one of them is going to be for my women who are not sexually active. They'll be like, "Oh, I didn't start it. I'm not sexually active. I don't need this." Like, yes, you do. It's going to help prevent your UTIs. It's going to help with your urinary symptoms. So that is a barrier for some of my patients. But again, it's that education to let them
Hmm.
know, this is what it's helping, and it's not just for pain with sex. Another huge barrier, the biggest barrier is going to be the box itself. The box tells patients they're at an increased risk of endometrial cancer, breast cancer, heart attack, stroke, and dementia. If you look at the data, none of that pans out. So we are actively trying to get the FDA to take that off of the label. We have already tried and failed multiple times.
Mm.
Hopefully, with this movement of women's health, maybe we'll get them to take it off here in the near future, but it scares patients. I do my best to, talk to every single patient before they walk out of the door, like, hey, the box is going to try to scare you, but I promise you, none of that actually pans out in the literature. And, so, some of them will still come back saying, nope, nope, I'm afraid. And then we can go over that again and we can go into more of the numbers as to why we think that vaginal estrogen is very safe. But again, when the box tells you all these things,
Sure.
you're gonna be afraid of it. So that is one of the biggest barriers that I do see. So kind of going back to the Women's Health Initiative, which is that study that scared us all in the early
Hmm.
2000s.
Yeah.
I mean, even when you look at that data, people who use vaginal estrogen, there was a lesser risk of coronary artery disease and all-cause mortality in the patients who used vaginal estrogen. So if you look at that
Oh,
same data, that's not so scary. So I'm hoping that again, as we spread the word and look at the data, that vaginal hormones will be less scary and that not only patients will be less afraid of them, but providers as well.
oh, for sure.
Yes, wait, let me make sure I got that right, because I think that's a great thing for I can start counseling my patients on. You said that in that study that you guys were now looking back at, we're saying that vaginal estrogen therapy or vaginal hormones do also help with some of that other benefit of the cardiovascular disease, I'm assuming
Yeah.
like bone health as well. You're saying that even if it's not a systemic hormone, that does have a benefit?
So not the bone health.
Okay.
That definitely is an important consideration for menopausal women, but the
Mhm.
vaginal hormones will not do that. However, I believe the thought behind why using vaginal estrogen helps with the cardiovascular risk or at least coronary artery disease is that there's just like less inflammation within the body.
Mhm.
So therefore less all-cause mortality, less cardiovascular disease.
I love that. I think that's like a very, like you said, a very not known statement, even in the primary care world and the women's health world. So I think that's great. So what are
Right.
your
And that's
thoughts?
literally straight from the guidelines. So
Okay, so I know I have not read my guidelines yet. They are
it's
printed
okay.
on
It's
my
okay.
desk. I'm going to sit there and do my homework after this. I wanted to get your sneak peek first. So, what are some of your thoughts about the new laser or energy based treatments that are being offered?
So the AUA did specifically put in the guideline that they do not recommend these sorts of treatments, and the FDA has apparently even released a statement about inappropriate and deceptive marketing for these devices.
Mhm.
Really, that's
Yeah.
not something that we're recommending here in our office.
So I know we're not supposed to, I mean, we can say brand names, so we're not supposed to like, promote or anything, but what are some brand names of some of those? Because I think that's what we see on the social media is they'll say, go get this done. So what was that well,
Yeah,
yeah,
the
tell me
Mona
some names.
Lisa, I believe,
Yes.
is
Yeah.
the
Okay.
big one. Yeah.
Yep.
Okay. So yes, that's why I was like, I need to know the names of these to
Yeah.
help.
No, I even like preparing for this is I saw a lot of advertisement for that. And it can be very deceptive as well as very promising on results.
But yeah, when the FDA comes after you saying that's deceptive,
Yeah.
that's a problem. Or,
Mhm.
this and not I love a good med spa, trust me. But like sometimes these like med spas will be like, oh, you can also sit and get these other treatments done
Mhm.
for vaginal health. And so it's good just to know, and like you said, you keep saying these guidelines are available for anyone to access and
Hmm.
read. And so it's
Yeah.
not just doctors. We're not, what do they call that? The young people call it gatekeeping.
Yeah.
Right.
We're not
Gatekeeping.
Do you know what
yeah,
was amazing? I had a patient literally last week who is also a breast cancer survivor and has been treated with, cream. She brought the guidelines in and she had them like
oh,
marked up. I was so excited. She's like, I'm sure you've heard of these. I'm like, yes.
I
So,
love
yeah.
Would
it.
have been
Isn't that
embarrassing if
amazing?
you're like, I don't know what you're talking
Yeah, that
about.
would be bad. But you know what?
Right.
I'm sure there are providers who are maybe, again, and maybe in the med spa world that are just kind of like, oh, this and that, taking the cash for all these things. And then they're not actually, or the influencers are online. They haven't read the guidelines. They're not up to date with some of these newer things that, talk about what works and what doesn't work, right? Okay, so we are going to switch gears now. We're going to go ahead and play our fun game that we always love to play, the fact or miss. So it's time to play. Kristen, are you ready for these?
I'm ready.
Okay, so these are ones that we pull off the internet, of course, usually from social media and stuff. And we're going to try to figure out if this is a fact or a miss. So, up first, Kristen, does your vagina disappear during menopause?
So technically that's a miss. But what has been going around social media is the fact that the labia minora disappear after menopause, and we can see that to varying degrees. And I even see that in some of my women who are perimenopausal. So the labia minora themselves, we do not have them. When we're born and when we're little girls, and we develop them in puberty, and again, they can go away or resorb in menopause. So you still have your vagina, okay? The vagina is still there, but the labia can disappear. And so the video that kind of went viral on that is Dr. Rachel Rubin, and she is fantastic. I heard her speak at our national guideline or at our national conference last year. I was like front row listening to her because she's fantastic. But you know what? She was on the guideline panel for this, and yes, she's big on social media, but she is doing the research. She's
Mm,
just trying to spread the word. So one of the reasons why I'm so passionate about this is because I've listened to her speak so many times. And again, she is pulling that data and she is telling you why she believes what she believes. And she will tell you when she doesn't know and when we
Right.
don't have that data. But she's fantastic. So
We'll
yes,
tag her in this for you, Kristen.
yeah.
fantastic.
Yeah.
Awesome. Very good. Okay, our second one is that the genitourinary symptoms of menopause can only occur in women over 40.
All right, so this is also a miss. So not only can perimenopause, that period of a roller coaster of hormones, that can start as early as 35. So I've been also putting that on my social media, like, hey, we have to start thinking about these things.
Hmm.
So not only that, but there's also a new term that we're coining called genitourinary syndrome of lactation. So in
Mhm.
lactation, we also have a low estrogen state to the vulvovaginal tissues, and we can have painful sex, we can have UTIs. Now, we don't have as much guidance as to, okay, what's the appropriate treatment, but it is very reasonable to offer these women vaginal estrogen and trying to and seeing how it affects milk supply. So again, there's more research to be done on that, but it mimics menopause. Other medications can also mimic menopause in my younger patients. So spironolactone, medication that's very commonly prescribed for acne, can cause very similar symptoms
Mm.
because it's blocking the androgens. And again, the androgens are so important to the health of those tissues. Combined oral contraceptives. So, most people, not most, but a lot of women are on birth control. And again, because of the low estrogen state, we can see some of these same symptoms. So again, more research needs to be kind of done as to how we can treat them, but it is very reasonable to give them vaginal estrogen and see if that helps their symptoms.
I had two friends that this happened to. Yeah. One was during lactation when she was breastfeeding her little one. Definitely this 100% happened. And then another one was with, I think it was with her IUD or something. She had something very similar. It was all this whole very interesting stage of life, and they're all in their 30s. And so it's something to keep that conversation going,
Absolutely.
obviously. Yeah.
Mm-hmm. Yes.
So, and our kind of last one would be, does treating genitourinary symptoms of menopause, can that help reduce the risk of urinary tract infections? Which I think we already know the answer since you've mentioned it a few times here, but maybe expand just a little bit about people with recurrent UTIs and how this could help.
Yeah, this is definitely a fact. So if you give vaginal estrogen to someone who has recurrent UTIs, it can bring down the rates of UTI down by half. So how that plays a role is when we go through menopause, again, that pH of the vagina goes up, and then all that good bacteria, the lactobacilli that we have in the vagina, go away, and the bad bacteria can thrive and lead to infections. We're also in menopause not getting rid of that epithelial layer quite as often. So we can have colonization within the vagina of the E. coli and again lead to infections. So when we give vaginal estrogen, it brings that pH back down to normal, promotes that healthy, good bacteria, and we have less infections. So you can kind of think of it as like a vaginal prebiotic, essentially. A lot of my patients will come in asking about probiotics for UTIs, but that's not part of our national guidelines. The data on that is kind of very back and forth, but the vaginal estrogen is very much part of our national guidelines for the UTIs as well. So we've been doing this for years now to prevent UTIs as part of our national guidelines. So yes, 100%, all of my patients who have recurrent UTIs, we do offer vaginal estrogen to help prevent them, and it does a really good job. So, there are so many patients that come and see me and have never been offered this as a treatment, and then, we start this and voila, their UTIs are better. Now, of course, that's not the cure for everyone, but it is the basis of what we do. And it is such a simple thing that, yes, I want all the primary care providers to be doing this because why wouldn't we want to prevent UTIs? So going back to my girl, Dr. Rachel Rubin, she's fantastic. Her group did a study, I think it came out last year, where if all of the Medicare aged women were on vaginal estrogen, it would save Medicare $6 to $22 billion a year. That is in, testing, that's in hospitalizations. Think about less hospitalizations, less antibiotic resistance, less C. diff infections. So there are just so many reasons to at least have this discussion. So any woman getting a UTI who's menopausal needs to be offered vaginal hormones.
Wow, I love that conversation.
Awesome.
Way to do like a mic drop there. I love that.
Right? See why I love her so much?
Yes.
It's so important, and that's why I thank you guys for having me on today because I want to spread the word. It's such an easy thing, and it helps so many women. So many women come back and are so thankful and want to give you a hug because they have less pain with sex, they have less UTIs, they can make it to the bathroom. So it's so important. And again, I appreciate you having me on.
Well, we appreciate you being on with us. As always, you're so informative. You're so enthusiastic about this subject. And so we're very, very appreciative. So if you guys are a listener claiming CME credit today, just please check those show notes for those instructions.
And for everyone tuning in, please don't forget to subscribe, follow us on Instagram and TikTok, and let us know what other topics you'd like us to cover. And we'll see you on the next episode of the MedEdit podcast.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.